So first of all, as you can see, I'm not Antonia Obrador. She couldn't talk today to moderate this session because she lost her voice, very convenient, at a very convenient time. So I'm Miriam Sanso, and I want to welcome you to the session on medical oncology. It is my pleasure to present the three speakers who will talk this afternoon. But in first place, I would like to once again thank all my colleagues and sponsors who have made this workshop possible. And I hope that you all enjoy these brilliant talks that we will have this afternoon. And without further delay, it's an honor for me to introduce you to the first lecturer of the afternoon, Dr. Cortés, Director of the International Breast Cancer Center, who is well known by all of you and a reference in the breast cancer research field. He is the author of more than 300 publications. He actively participates in the development of numerous international clinical trials that led to the approval of several drugs on breast cancer. And he actively participates in different associates like SEOM, ESMO, and ASCO. And in addition, he's a member of the scientific committee of the European Society for Molecular Oncology. Today, he can talk about many aspects of the breast cancer, but today he will focus on the role of immunotherapy in one of the most aggressive breast cancers, the triple-negative one. So, Dr. Cortés, whenever you want.
Thank you very, very much. Let me share my screen first. Can you see my screen?
Yeah.
Okay. So in English, correct?
Yeah, better.
Okay, perfect. No worries. Okay, first of all, I'd like to thank you very, very much for inviting me to be here with you today to discuss a little bit about one of the most exciting systemic therapies we have in the field of breast cancer in general and in the field of triple-negative breast cancer in particular, what is immunotherapy. And I will try to discuss with you the role of these new agents in this field. So these are my disclosures. As you all know, triple-negative breast cancer is a very heterogeneous disease. And when you look at the gene expression, you can observe that there are different analyses, but I like this one in particular, which is the Baylor-based gene expression subtype analysis. And they have defined like four: the basal immune activated subtype, basal immune suppressed, mesenchymal-like, and luminal androgen receptor subtype. So when we look at this in the clinic, we say, is this of help or not? So to be very honest, today this is not of help in the clinical practice. It is for the clinical research and for the translational research. But I'm quite sure that in the very next future, we will be able to define which are the optimal drugs to be decided depending on this or other genomic expression subtypes. Today, we are going to talk about triple-negative breast cancer, which is only defined as ER, PR, and HER2 negative. And again, this belongs to the future. And it is true that when we are looking at different subtypes, different heterogeneity of the tumor, it seems that there is a significant group of patients which might have this basal immune activity subtype that probably are the ones that might benefit more from immunotherapy. And our challenge is how can we optimize immunotherapy to be able to help many of the other patient population. So why triple-negative breast cancer is a target for immunotherapy? And this is a very often slide, is something we present in all meetings. But I think it's very easy to understand. First, triple-negative breast cancer has a higher mutation rate compared with other breast cancer subtypes. Basically, compared, for example, with the luminal, with the estrogen receptor subtype. Also, when we look at the TILs, the tumor-infiltrating lymphocytes, we also observe that triple-negative breast cancer is usually enriched in TILs compared with other tumor types, and also the PD-L1 expression. Also, PD-L1 is expressed higher in triple-negative breast cancer compared with other tumor types. So I think that in brief, all these aspects highlight that probably immunotherapy or immunology or microenvironment is more immune affected in triple-negative breast cancer compared with other tumor types. So the first question is, okay, this is great, this is beautiful, but which data do you have in terms of immune checkpoints, in terms of immunotherapy in the field of triple-negative breast cancer? So poor. This is the data we have. Atezolizumab, which is an anti-PD-L1 inhibitor, or pembrolizumab, an anti-PD-1 drug. So immunotherapy, single agents in triple-negative breast cancer in the first-line setting, overall response rate in the range of 23 to 26%. In the second line or beyond, overall response rate in the range of 5%. So very poor responses. Nevertheless, the duration of response, so those patients who achieve a partial or complete response, small number of patients, but look at the median duration of response, will be very prolonged, even in some cases more than 20 months. So which data do we have in terms of randomized clinical trials with immunotherapy single agent? We have the Keynote 119. This is a randomized phase 3 study in second line or third line triple-negative breast cancer, pembrolizumab single agent against physician's choice. Co-primary endpoints were overall survival in patients with CPS score 10 or more. CPS, I will discuss this further, but basically is in patients with high PD-L1 expression. Also in CPS 1 or more, less expression, and also in the intention to treat population. And here you can see the results. The hazard ratio, 0.97 in the intention to treat, 0.86 in CPS 1 or more, 0.78 in CPS 10 or more overall survival. So based on the p-value, this trial failed to demonstrate an improvement of pembrolizumab compared with chemotherapy. So pembrolizumab did not significantly increase overall survival in this second, third line of treatment. However, in a small number of patients, those one with a CPS score 20 or more, so very, very high expression of PD-L1, this was an exploratory analysis, but look at the interesting hazard ratio, 0.58. The median moved from 12.5 months survival with chemo to about 15 months with pembrolizumab. Look at, nevertheless, the median overall survival when we are talking about second, third line triple-negative breast cancer in the range of 10 to 12 months. So very poor overall survival. So based on this data, pembrolizumab not improvement in survival, exploratory analysis, maybe there is a subgroup of patients with very high expression of PD-L1, but maybe immunotherapy might work. So can we optimize immunotherapy? Certainly, yes we can, but in combination with chemotherapy. Why in combination with chemotherapy? Because chemotherapy induces different immunomodulatory changes in the tumor microenvironment. Chemotherapy increases antigen release, upregulates PD-L1, upregulates immunogenic cell surface markers. So in other words, so updates the immunomodulatory markers that might improve the efficacy of immunotherapy. So which data do we have in the clinic? We have 3 randomized phase 3 studies, IMpassion 130, IMpassion 131, and Keynote 355. We have a 4th clinical trial, IMpassion 132, which is at this time enrolling patients. So we, of course, do not have data. So IMpassion 130, this was the first randomized phase 3 study. All of these trials in the first line setting. IMpassion 130, nab-paclitaxel or Abraxane with placebo or atezolizumab, co-primary endpoints, PFS, progression-free survival, and overall survival in all comers, intention to treat PD-L1 positive and PD-L1 negative. IMpassion 131, first line, paclitaxel atezolizumab or paclitaxel placebo Primary endpoint, progression-free survival in the PD-L1 positive population. And last but not least, Keynote 355, again first line, chemotherapy placebo, chemotherapy pembrolizumab. And here, the chemotherapy backbone could include or paclitaxel, or nab-paclitaxel, or carboplatin plus gemcitabine. Co-primary endpoints, progression-free survival and overall survival, but in the PD-L1 positive population. Results. In PAS 130, nab-paclitaxel atezo, nab-paclitaxel placebo. Intention to treat, hazard ratio 0.80 for progression-free survival, positive study. So based on this data, we looked into the PD-L1 positive or PD-L1 negative population. You can observe here that the improvement in PFS was clear in the PD-L1 positive population, hazard ratio 0.62, and the median moved from 5 to 7.5 months. Nevertheless, the second co-primary endpoint, overall survival, hazard ratio 0.87, p-value 0.077, it failed to demonstrate an improvement in survival. Nevertheless, an exploratory analysis in the PD-L1 positive population hazard ratio 0.67, very nice improvement in overall survival. But again, based on the design of this trial, the PD-L1 positive population overall survival was only exploratory in nature. It is not a pre-planned analysis based on the negativity for the intention to treat overall survival data. In person 131, paclitaxel atezo, paclitaxel placebo. Primary endpoint, PFS in PD-L1 positive population. Unfortunately, a negative study. Different hypotheses about why. In my opinion, again, this is my opinion, it is not science-based. I think it was by chance. I think that when you look at the hazard ratio 0.82, look at the hazard ratio in the other part of the slide, 0.62, so the confidence intervals were overlapping. I think that atezolizumab also might have paclitaxel, but that's my personal opinion. Obviously, according to this trial, paclitaxel and atezolizumab is not superior to paclitaxel and placebo. Finally, Keynote 355, remember, chemotherapy plus pembro or chemotherapy plus placebo, nice improvement in the hazard ratio 0.65, nice improvement in median PFS from about 4.1 months, from 5.6 to 9.7 months. Remember, in this case, primary endpoint PFS in the PD-L1 positive population. So this year at ESMO, we updated and presented the final overall survival, and also pembrolizumab improved survival. Here you can see the great overall survival data. Hazard ratio 0.73, and the median move from 16.1 months to 23 months. Almost 7 months improvement in overall survival. When you look at the overall survival in patients with CPS 1 or more, we failed to demonstrate an improvement there. So based on all these data, pembrolizumab improves PFS and survival in patients with high PD-L1 expression measured with a CPS score of 10 or more. So the next question is, which is the ideal partner to be combined with immunotherapy? This is a beautiful, small randomized phase 2 study published in Nature Medicine 2 years ago. And you can observe here that, in brief, so depending on the chemotherapeutic drug that you combine with immunotherapy, nivolumab in this study, another anti-PD-1 inhibitor, the benefit in terms of overall response rate could be different. With cisplatin, about 23%, with anthracyclines, 35%, with other approaches, cyclophosphamide or irradiation therapy, in the range of 10%, 8% in this case. So maybe the partner matters. Nevertheless, we analyze this in the Keynote 355, and what we observe is that all of them, nab-paclitaxel or paclitaxel or carbogem, when combined with immunotherapy, we improve outcomes. So remember the Keynote 355 here. Remember the impassion. No with paclitaxel, no with paclitaxel, yes with nab-paclitaxel. In my opinion, it does not matter if paclitaxel or nab-paclitaxel. Again, in my opinion, with atezolizumab was a chance. Can biomarkers help us to define which patients benefit more or less? Absolutely, absolutely they help. Here you have the PD-1 assessment. It is a nightmare. So we have so many different variables to take into account to consider how to optimize the PD-1 assessment that it is a nightmare. Should we define PD-1 positivity in tumor cells, in immune cells, in both? Which is the optimal modality of the scoring calculation? To enumerate all the positive cells or the area occupied by positive cells? What is the cutoff value? 1, 10, 20, 50? Also, it depends on the tumor type. In lung cancer, in renal cell carcinoma, 20 or 50 are the optimal cutoffs. Here it seems to be 10 when we use pembrolizumab. Which is the optimal antibody clones? SP142, like atezolizumab, 22C3, like pembrolizumab, or other ones, and the optimal platform to be used, Meltana, Daco. So it's a nightmare. Each company has its own type of cells to be considered, motif scoring, cutoff, primary antibody platforms. So clearly what we have learned is that if we go for atezolizumab, we should go for the SP142 antibody and Mentana assay. If we go for pembrolizumab, 22C3 antibody and DACO assay. Why? Because the concordance is not perfect. Look at in this slide the beautiful analysis our friends from the Impassion 130 did. They analyzed the PD-1 prevalence with different assays, and we can observe here that the concordance is about 35%, 34% if you want to be exact. And when we analyze the CPS score 10 or more, then the concordance was in the range of 3 out of 4. So 74, 75% concordance. The next question is, how can they compare in the clinical practice? Again, let's analyze this data in the Impassion 130. Remember, this study was developed with the SP142 antibody. So when these patients or these tumors did not express PD-1 with the SP142 antibody, but did with 22C3, these patients did not have any benefit of adding atezolizumab. And finally, where should we look at the PD-1 expression? In the primary tissue or in the metastatic disease? In the primary tissue, it is expressed in the range of 45% of patients. In the metastatic disease, in the range of 35%. However, also it depends on the anatomical location. For example, in the liver, it's very rare to have expression of the PD-L1, about 13% of patients. However, in the breast, in the lymph nodes, in skin, it could be in the range of 50%, 50. So how does this correlate with efficacy in the clinical practice? Once again, beautiful data from Impassion 130. Doesn't matter if the positivity comes from the primary tissue or the metastatic disease. It seems to produce similar benefit. Finally, I think there is an important analysis also in Impassion 130 regarding the tumor microenvironment. And look at the following data. 3 key comments. The first one, they beautifully analyzed the inflamed compared with the excluded or the immune desert tumors. So inflamed, all tumors were full of TILs. Excluded, TILs were surrounding the tumors. In desert tumors, no TILs at all. And it seems that when we look at the PD-1 expression, this does not matter that much. But in the PD-1 negative population, maybe tumors which are inflamed or excluded might have some benefit from adding atezolizumab. Definitely, desert tumors with no expression, no benefit at all. What about molecular subtype? Remember the first slide I presented? It seems that when we have PD-1 positive tumors, basal-like immune, but also basal-like immune suppressed tumors might benefit. In the PD-1 negative population, if we have a basal-like immune activated subtype, maybe we have some activity. But for sure, For mesenchymal-like tumors or luminal androgen receptor-like tumors, no benefit at all, even though these patients have or not PD-1 expression. And finally, which I think is very, very interesting, they also analyzed different tumor microenvironment pathways. And we can observe here that, for example, for those tumors who had activation in the angiogenesis pathway, even in the PD-1 positive population, maybe the activity of immunotherapy is not that big. And the other way around, for neutral or for those patients with mitotic-like pathway active, these patients might benefit clearly for immunotherapy. So there are pathways that might correlate with activation or with sensitivity or resistance to immunotherapy. So based on this data, we have conducted this, in my opinion, very beautiful clinical study. It's a phase 2 study, single cohort phase 2. All patients in the first-line setting receive paclitaxel, atezolizumab, and bevacizumab, an anti-angiogenic agent. We have enrolled in the range of 40 patients so far, terrific activity with this triplet combination in both PD-1 positive and PD-1 negative. So I think that in the future, we will work not only with a PD-1, but also with other aspects. And we will be able to define a breast cancer immunogram, not only with PD-1, but something other biomarkers beyond PD-1. And depending on this, we will define if these patients should be treated or not with immune-based approach. So some comments now about immunotherapy-related toxicities in metastatic triple-negative breast cancer. Here you can see that with chemotherapy, we have predictable toxicities. With immunotherapy, it is very unpredictable. So the incidence is different. With chemotherapy, the majority of patients will have some type of events. With immunotherapy, just a minority of them. Adverse events are very variable with immunotherapy. Any organ can be affected. And very, very important, we can stop immunotherapy today and have toxicity months or even years after. So if a patient has received previous immunotherapy, careful with these patients and follow them for a prolonged period of time. You can see here that the great majority of the immune-mediated adverse events with immunotherapy single agent is hypo or hyperthyroidism, but many others might appear. And we combine immunotherapy on top of chemotherapy. We observe that adverse events are very similar, but immune-mediated adverse events, of course, are much higher when immunotherapy was combined. Once again, even with chemotherapy, hypo or hyperthyroidism were the most important toxicities. Same observed in Keynote 355. So in brief, and a summary here, I think that adverse events were very similar, but immune-related adverse events were much higher when immunotherapy was added to chemotherapy. Some comments in the early triple-negative breast cancer setting. We have a plethora of clinical trials here, and I will not go into discuss all of them. It's very, very boring. I will only discuss 2 of them. These are the most important clinical trials randomized phase 3 in the field of early triple-negative breast cancer. Keynote 522 and Jeopard-12. Jeopard-12, we still do not have data yet. So I will not make any comments, but it is a very, very important study. Carboplatin paclitaxel followed by anthracyclines with placebo or with atezolizumab. Let me stop in the Keynote 522. Paclitaxel carboplatin followed by anthracycline-based therapy with placebo or with pembrolizumab, followed by surgery, followed by pembrolizumab or placebo. Patients with stage 2 or stage 3. Primary endpoint, co-primary endpoints, pathological complete response, and event-free survival, or invasive disease-free survival. Here we have the first co-primary endpoint. PCR improved from 51% to 65%. And very interestingly, when we look at the analysis in stage 2 or in stage 3, we observe that all patients, all stages benefit importantly, but the amount of benefit, the absolute benefit, was much higher in patients with stage 3. So in the same way, when you look at the improvement in PCR in patients with lymph node negativity, it was in the range of 6%. It was 20% for patients with lymph node positive. And very interestingly, remembering the metastatic disease, that patients who benefited from the addition of immunotherapy were those ones with PD-L1 expression positive. Here, it doesn't matter. Patients with CPS score 1 or more, or even CPS negative, so PD-L1 negative, PD-L1 positive, benefited exactly the same. So this year at ESMO virtual meeting, Peter Smith presented the updated data of the Keynote 522, and we can observe here that pembrolizumab did not only improve PCR, but also improved disease-free survival. Look at the hazard ratio and look at the number of events. 16% with pembrolizumab, 24% with placebo. So almost an improvement, an absolute improvement in 8%. Very, very significant improvement in invasive disease-free survival. Based on this data, Keynote 522, pembrolizumab was approved recently by the FDA. And finally, another important study I would like to present is around my phase 3 study, by the primary endpoint being only pathological complete remission. Nab-paclitaxel anthracyclines with placebo or with atezolizumab, stage 2, stage 3. Look at the data. Very, very, very similar data. Clearly improvement in pathological complete response. Very nice improvement independently of the PD-L1 positive or PD-L1 negative. And also very preliminary, it was not the primary endpoint, but you can observe that the hazard ratio for event-free survival, disease-free survival, and even for overall survival was very nice in favor of atezolizumab. So just 2 more minutes. You said I have 40 minutes. I will do it in 30 minutes. So just 2 more minutes just to highlight 2 key aspects of immunotherapy in other breast cancer subtypes. Let me start with the estrogen receptor positive tumors. Very modest activity of pembrolizumab, avelumab, single agent in the range of 3 to 10%. We presented and published this data in the European Journal of Cancer, phase 2 study of eribulin plus pembrolizumab in second, third line, overall response rate, very, very interesting, very, very interesting. And median PFS also interesting, in the range of 6 months median PFS, overall response rate in the range of 36%. Eribulin only, overall response rate in the range of 20%, median PFS in the range of 4%, or 4 months. Nevertheless, around my phase 2 study, very small, published by the Harvard University folks, no improvement when pembrolizumab was combined with eribulin. I think that we have to explore much more on this. Finally, in the HER2 positive field, there is a randomized phase 2 study, CAPE2, T1 placebo, T1 atezolizumab, primary endpoint progression-free survival in the intention to treat population. It failed to demonstrate an improvement, so the PD-L1 positive population subgroup, very nice data, very nice hazard ratio 0.60, but only exploratory. And same happened with overall survival. Not improvement at all for survival in the intention to treat, but also very interesting data in the PD-1 positive population. So just to conclude, single agent anti-PD-1, anti-PD-L1 drugs in triple-negative breast cancer seem to be less active than when combined with chemotherapy. However, it seems that first, in the first-line setting, more activity, and mainly for selected patients with a very high expression of PD-L1, immunotherapy might work. Second, nab-paclitaxel plus atezolizumab in the first-line setting improves progression-free survival in patients with PD-L1 positive triple-negative breast cancer, and a very interesting signal also in overall survival. Chemotherapy plus pembrolizumab, nice improvement in PFS, but also overall survival. And what is very, very clear, that the effect is only in PD-1 positive tumors. Immunotherapy in other tumor types, preliminary activity, more clinical trials are needed. Finally, in the early breast cancer setting, atezolizumab plus nab-paclitaxel, interesting activity in terms of PCR improvement. Pembrolizumab plus chemotherapy improves PCR, improves invasive disease-free survival, and it is approved in the United States. However, the effect is not limited to PD-1 positive tumors. In my opinion, without taking into account the regulatory perspective, only the scientific perspective, in high risk stage 2 or stage 3, I think that the combination of immunotherapy plus platinum-based, followed by anthracyclines, should be, in my case at least, the preferred option, followed by surgery, and if PCR, continue with immunotherapy only up to 1 year. If non-PCR, immunotherapy plus capecitabine. My friends, with this, I would like to finish. I'm more than happy to answer any questions. Thank you.
Thank you very much, Dr. Cortés. Now, if anybody has a question for the speaker. You, please.
Can you hear me? Yeah. Hi, Dr. Cortés. Thanks for your talk. I wonder, I would like to know your opinion about the epigenetic drugs that maybe they can boost the immunogenicity, and how is this topic going in clinical trials and in the bench side, not in the bedside, not in the lab. That is where I am. And if you think that they are promising, then they can help to extend these treatments to other patients.
So no, thank you very much. I think it's a terrific question. So I'm not an expert on epigenetics. Nevertheless, what I can tell you is that there's a plethora of targeted agents which are being at this time explored in combination with immunotherapy and also with chemotherapy. So with both. Okay. So of course, I do not know if this will help patients or not. But my comment, the only thing I can tell you is that it makes terrific sense. From the preclinical perspective, this makes a lot of sense. But I do not know, I'm sorry, I cannot answer you if there are ongoing clinical trials at this time exploring this strategy in combination with immunotherapy. I know there are different strategies in combination with endocrine therapy, in combination with chemotherapy as well, but I don't know if there are any in combination with immunotherapy. I think it makes sense and should be combined. But to be very honest, I do not know if there are any trials ongoing.
So I have a question, if nobody else raises the hand. You talked about the different biomarkers, predictors of response, PD-L1, the inflammation, the subtype. But TMB, that you mentioned, it seems not to be so good for breast cancer.
Which one? Which biomarker?
The TMB, the tumor mutational burden.
Yeah.
So, do you have actual data about segregating all these results depending on the TMB score?
Yeah, that's a lovely question. So I didn't talk about many other biomarkers because but you are right. Okay, so immunotherapy now, pembrolizumab at least, has been approved in the United States and also in Europe, based on the microsatellite instability, MSI high, but also in the United States, pembrolizumab has been approved based on a small group of patients with high TMB. It was defined as 10 or more mutations by megabyte. So the answer is yes, we have some data. The overall response rate is not very interesting, but it's in the range of 20 to 30%, more or less. We have more data in other tumor types. But again, the FDA approved pembrolizumab also based on TMB. I have used this in 2 patients. I had one beautiful response in one of them. It was PD-1 negative, by the way. The other one, the other patient progressed quickly. But yes, the drug has been approved in the US and is clearly promising.
Yeah, I was just wondering because also ApoBec is a signature of this kind of
Right,
cancers, and
right.
it's important one.
Right. So that's another question. And you know, we have ApoBec, we have many others. So I think that, and that's also my personal opinion, okay, I think that the future of cancer, the future of breast cancer, and the future on immunology will not be based on isolated biomarkers. I think that we have to work on signatures. And I don't know which is the optimal signature to look at. But when we have looked at different signature or immune-based signatures, this seems to be the best predictive biomarker for patients to respond to immunotherapy. So I think that PD-L1 is something very easy, but in the future, in the very next future, I agree with you, ApoBec is just, again, one of them, but we have different signatures that can optimize clearly which patient will benefit more or less from immunotherapy, but for the majority of the treatments.
Thank you very much. Another question from Diego.
Yes. Hello, Dr. Cortés. I'm Diego
Hi,
Marcese. Thank you so much for joining us, and it's an honor for us to have you here. I will continue in line with the question by Miriam. Apparently, we were thinking exactly the same issues in this, to enhance the application of immune therapy on TNBCs. Related to the lack of consensus or gold standard for biomarkers to predict which patient is going to respond or not, I will abuse of your tremendous understanding of the clinical trials that are ongoing and completed. Have you seen data from analysis combining biomarkers? I mean, patients with high TMBs plus high TILs versus different combination of combining these biomarkers, or not?
Yeah, no, there are some data looking at that. I thought it was for a clinical perspective. That's why I did not enter into biomarkers. Happy to talk about biomarkers all the time if appropriate. No, yes, certainly there are beautiful data how to, for example, the number of TILs and the PD-L1 expression, both of them can add predictive value to the prognosis of atezolizumab and or to pembrolizumab. So with the mutation tumor burden, if this can add any predictive value to PD-L1 expression or to TILs, to the best of my knowledge, this has not been seen in triple-negative breast cancer. But there are many other biomarkers which are in the clinical development. I'm not talking about just CTLA-4, OX40, and many others. I'm talking about many other clinical biomarkers. I'm talking about ADH. I'm talking about disease burden. I'm talking about liver metastasis. I'm talking about clinical aspects that also might be predictive of immunotherapy response. But the question is, in terms of TILs and PD-L1, yes, they have additive predictive role. In terms of mutations, I think it has, at least I have not seen this data. I think I cannot add, in addition to PD-L1, as an independent predictive marker. But again, I can be totally wrong about that.
Thanks for all. Oh, you have another one.
Yes,
okay,
sorry,
Diego.
another question. What a tremendous time to be alive on this treatment for TNBC patients. I am amazed with the data for the early breast cancer response. I know we are too early, but have you seen any follow-up data on patients that showed residual disease after surgery? Have they relapsed better, or what?
So no, that's a great question, Diego. So what we have here is something very, very interesting. What we have seen is that in patients with non-PCR, okay, those patients who receive pembrolizumab did have much better outcomes than those patients who did not achieve PCR and do not receive pembrolizumab. So it seems that immunotherapy might be of help, not only to increase PCR, but also to optimize the prognosis and independent of the PCR. If this is because we are having more RCB 0-1 compared to 2 and 3, or this is because we are changing the biology, or this is because the lymphocyte activation might act later in time. This is not known today. If we are changing the type of relapse, liver metastasis compared with brain metastasis, whatever, this is something we are analyzing. We do not have this data yet. And finally, if the prognosis of metastatic triple-negative breast cancer is different in those patients who received or not previous immunotherapy in the early breast cancer setting, is also something which is clearly of interest, but is not known today. So the only thing we know is that the prognosis for both PCR and non-PCR is better if they receive pembrolizumab. We do not know why this happened. Did I answer your question?
Amazing. Yeah, absolutely. Last one.
This is something great for the lab. I think this is, it might be absolutely terrific. Can we change the molecular environment, for example, with eribulin, which is a chemotherapeutic compound, in triple-negative breast cancer? We observed that the PFS is identical, survival is longer. Why? Because it seems that we change the mesenchymal to epithelial phenotype transition into the mesenchymal-like into the epithelial-like. So we might change the biology of the tumor. So maybe this is something that might also happen with immunotherapy.
Amazing. Last question, I promise. So probably linking a little bit with the next talk we have. You show data that really show a better difference in stages 3B, AB. So I assume most of these patients were clinically positive nodes, axillary nodes. Have you seen, is this data showing any differential response in the primary versus the burden in the axilla, or is there no difference in the response of these two areas of tumor?
So that's a good question, very interesting, and this is a clinical question.
Yeah.
So we have not analyzed this specifically, or at least I am not aware about that. What I can tell you is that in the clinic, I have treated now with immunotherapy plus maybe about 15 patients, 15, okay? And I have seen about 60 to 70 PCR. And I can tell you that I am not aware about different activity in the tumor compared with the lymph nodes. I think it's quite similar. I think that it works both very nicely.
Thank you so much.
Pleasure.
Thank you, Dr. Cortés.
Any other question? We have a few minutes.
Okay.
No more questions.
So thank you very much for this amazing talk about very complicated data, complex and so well explained.
I'm sorry, I'm an expert in breast cancer. Maybe in other tumor types, they have much more experience about immunotherapy, our lung colleagues, our melanoma. But in breast cancer, we have just started. So these drugs were approved last year. And in early breast cancer, only by the FDA 2, 3, 4 weeks ago. So it's very early, and of course, we'll have to learn much more about this compared with from our friends from other pathologists, and also from you, from the preclinical perspective.
Thank you.
Thank you again. Thank you.
Thank you very much.